Good morning again. We have to introduce Dr. Mohammed Salem. He is consultant and lead clinician cardiothoracic anesthesia and critical care, John Radcliffe Hospital, Oxford, University Hospitals, National Health Services Foundation Trust. Welcome, Dr. Mohammed. The floor is yours.
Assalamu alaikum. I was, of course, as you could see, I'm not an obstetrician. I'm an anesthetist, intensivist in Oxford. And this is my first time in Jerusalem. And on my way here, I was detained at the airport for about 3 hours. And a lady from passport control asked me why I was invited. And I looked at her confidently and I said, I'm a very good speaker. So I'd like to hear your feedback at the end. This is my childhood. Both my parents are obstetricians, so I grew up learning about obstetric hemorrhage, and I could share experiences from both sides. And because the talk is about innovation in obstetrics and gynecology, I tried to find something that's related to Oxford, and this is recent. And my colleague Isabella there is a transplant surgeon who's part of the transplant team at the Churchill, and they performed a living donor uterus transplant in the UK. But of course, if you look at innovation in management of bleeding, I think you would expect that this is what you get if you think you can work out that something is going to happen. And for the non-Arabic speakers, this just says that you've just passed a speed bump. But actually there is machine learning that is actually looking at hypertension prediction, and that you can predict major blood loss that's about to happen, but it's still in its infancy stage. And of course, because we're talking about postpartum hemorrhage, we have to bring up the Taj Mahal, which is a monument that was built for a lady that died as she was giving birth to the 14th child of major hemorrhage. And to put things into perspective, this is the micromort, which is a unit that looks at the incidence of or risk of death in 1 million. And you can see down here that giving birth is actually quite a risky thing. I don't know if you can see a pointer here. But the risk of giving birth is about 120 per million, and a cesarean section is about 430 in a million. And of course, the maternal mortality, or the inquiry into maternal death in the UK, found that there is about 9 deaths that happened between 2006 and 2008. And the management of these cases was often suboptimal. And they came up with clear policies to manage these cases, and training of frontline staff to recognize the delivery when it's going wrong, to order blood, request blood, and give blood in a timely manner, to train the frontline staff, and to train on communication, because it's very important. And this is data from the serious hazards of transfusion, and you can see clearly that there are still deaths that are occurring because of delay in transfusion. And you could clearly see that there's hemorrhage still is there and there. And of course, because I give this talk in the management of placenta, accreta, and pericreta, these are the 6 elements that are reflective of good care for these patients, which is having senior obstetrician, anesthetist, blood products and blood available, a multidisciplinary team, and a decision in advance of time is when to do a hysterectomy, and the availability of intensive care beds. So planning is very, very important in the early stages when you think that something is going to happen. Clearly, because you don't want to be facing a difficult situation, you have to make decisions such as this. So in my MBA, I came across this slide, and obviously you have to take decisions. Are you going to change the line of the cart and save 5 people's life but sacrifice 1 life? And obviously you can think of a hysterectomy as a changing in a family situation, especially in the Middle East. So if we're talking about where women with placenta, accreta, and pericreta should be cared for, it should be done in a multidisciplinary team with a special units where they actually have got available resources at hand. And of course, this is not a one-man show or a one-person show, shall we call it. You have to have a massive team, and this is sort of the team I work with in Oxford. And you can count almost about 13 people here in this picture. And of course, there are people behind the scenes, the porters that get the blood, the people that work in the lab who help save people's lives. And of course, because we're talking about planning ahead of time, you can work out what is your maximum blood loss before you start to trigger for a transfusion so that you can order the blood. And this is a very simple equation. So an adult woman will have about 65 mils per kilogram. So you can multiply her estimated blood volume, and then you work out her initial hemoglobin minus the transfusion hemoglobin, which you're going to work at, which is usually 70, divided by the average hemoglobins, and you come up with a figure. And as soon as you're almost about 75% there, you should start thinking about ordering blood. But ideally, you should have cell salvage in place, which is endorsed or recommended by the NICE guidelines. And more frequently, we started using this Belmont rapid infuser, which is capable of delivering up to 1 liter per minute of blood. So you shouldn't call for help if needed. You should have help available at hand. You should have a gynecological surgeon or a gyne-oncologist. And this is sort of the team that I've worked with over the last few years in the placenta accreta precreta spectrum, and they've come to be very good friends of mine. And yesterday we heard a very interesting talk about the embolization and the interventional radiology, so I will not go into that. But what about what sort of anesthetic management? Are you going to start, or should we start with a spinal or a general anesthetic? So usually going with a spinal anesthetic and converting to a general anesthetic if needed. However, general anesthesia has often a bad reputation. It's associated with more morbidity and more hemorrhage. Monitoring for sort of patients that you're anticipating blood loss, you should have at least invasive arterial line, which will give you a beat-to-beat blood pressure variation. And all the AI, the hypertension prediction, will work on a transduced wave to predict the stroke volumes and if there's any hypertension to happen. And of course, before talking about major hemorrhage, you have to define it. And I think the easiest way is to say that it is blood loss in excess of 150 mils per minute. And to go into the sort of obstetric physiology, if the uterine blood flow is about 700 mils at term, or 10% of the cardiac output, so you can only do the maths and wonder that actually within less than 10 minutes, you're facing major hemorrhage. And obviously, you'll be in class 3, class 4 sort of hemorrhage as you can see here. And within minutes, you'll be facing shock and then systemic endotheliopathy with coagulopathy later on. So the therapeutic goals are basically to maintain tissue perfusion and oxygenation, restore the blood volume, stop the ongoing blood loss, which is an ongoing effort between the anesthetists and the surgeons, and manage the complications of bleeding if they should occur. And this slide clearly highlights any management in terms of cardiac output. So you need to maintain oxygen delivery, and oxygen delivery is a product of cardiac output and arterial oxygen content, which itself is a precursor of hemoglobin and the arterial oxygen saturation. However, you can maintain the cardiac output by preload, afterload, and contractility. And this is easily done by giving fluids or adding a vasoconstrictor initially until you can figure out what the problem is. So immediate actions, you should send immediately for blood, put a few IV large axis cannulae, fluid resuscitation with warm fluids, group O negative blood if you don't have any group specific cross-matched. Actively warm the patient and then notify the lab because you're having an abnormal situation, and if you have cell salvage, it would be great to have it at hand. The answer to this question is obviously yes. You should at least have 2 large bore cannula, because you can see that you can transfuse at least 300 mils plus per minute. which will get you out of trouble. You should notify the switchboard, which will get you immediate attention from the hematologist on call to help, the senior intensivist, an intensive care nurse, a surgical team that can help, and a radiologist on call if you need to embolize. You should target systolic blood pressures between 80 to 90. Do not try and achieve normality because you will lose more blood this way. Administer vasopressors and fluid to maintain the target arterial pressure. The CRASH-2 trial looked at the tranexamic acid, which I think is very, very important, and it cannot be underestimated that the earlier you give the tranexamic acid, the better. If you give it later on, it's not going to do any good. And obviously, the woman trial has showed the same thing, but actually, what's more important is that tranexamic acid in these ladies, when given within 3 hours, substantially reduces the risk of death. Hemoglobin, you should, if you start with a low hemoglobin, it is a bad situation, and that is a prediction that you're actually going to run into more trouble. Use repeated sort of point-of-care tests and transfuse to a hemoglobin of 70. And this is the TREC trial, and this is a trial that was done in Canada some time ago in over 22 units, and they looked about 800 patients who were randomized to a higher target hemoglobin versus a lower target hemoglobin, and the lower or the less liberal transfusion group had less mortality. This is a point-of-care test that we do in intensive care, in our cardiac intensive care, and it takes about 30 minutes. And it gives us data that we can actually either give fresh frozen plasma, cryoprecipitate, or platelets. And it's basically gives us the R time, which is the time from the start forming clot. And if it's deficient, we usually just give fresh frozen plasma. And if the split, which is the MA, is deficient, we give platelets and fibrinogen. And I'll explain later on. Because low fibrinogen is actually a marker associated with the occurrence of severe postpartum hemorrhage. So if you send fibrinogen early on, you should try, and you find it low, try and give fibrinogen or cryoprecipitate as soon as you can. And I'm just going to skim because these are all pretty much saying the same thing. And if you think that there is a ratio that needs to be done here. So if you have bleeding, just don't give blood. You have to actually give a blood, platelets, and cryoprecipitate in a ratio of 1 to 1. And target your INR. So INR should be less than 5 and an APTT of less than 36 because this will take time. And you should give cryoprecipitate if fibrinogen is less than 1.5 and platelets if your platelet count is less than 50,000. You should prevent and treat coagulopathy, so actively warm the patients as soon as possible. Treat acidosis, hypercalcemia, hyperkalemia. Serum lactate is a marker of cardiac output, and it was a predictor of systemic shock. And if all pharmacology fails, you should initiate intrauterine tamponade, surgical hemostatic techniques, or interventional radiology, as we've talked about before. And obviously, you can try and compress the aorta while your hand is inside against the spine, and that might buy you some time. And this is a paper from some of colleagues I met, and they've devised a technique that they actually pass a Foley's catheter around the cervix to try and reduce the blood loss before they incise the uterus. And this is a patient who's had cardiac surgery, and this is a patient who's had about 13-hour operation. Obviously, they're coagulopathic. We don't have the luxury of being able to pack the chest because we compress the heart and the heart will stop pumping. So the sternum is open and the chest is left open. And basically, we take them to intensive care, treat their coagulopathy, and take them back to theater in about 12 hours. So if all else fails, just pack the abdomen, take the patient to intensive care, and bring them back later on. Consider early hysterectomy, because if you start thinking about hysterectomy late, the clock is already going, and actually it might make the situation a bit worse. Nova 7, I spoke to a lot of hematologists. There's no evidence to support it, but if your back is against the wall, we just give it sometimes. The complications of blood transfusion, obviously, these are the simple ones, which is either a allergic, febrile, or mixed reactions. And basically, you more often than not have the mild reaction. You just give an antihistamine or a paracetamol. In more severe situations with an anaphylaxis, you need to initiate an anaphylactic protocol, which I've luckily not encountered at all. Other complications include TRALI, which is the transfusion-related acute lung injury, the TACO, which is the transfusion-associated circulatory overload, and the TAD, which is the transfusion-associated dyspnea. And obviously, the TRALI is the worst one out of all of them. So you've done the procedure, the patient is taken to intensive care, still intubated and ventilated, and within a few hours, they become hypoxic. Their chest X-ray is done, and there's clear evidence of what looks like pulmonary edema, but there is no evidence of left atrial hypertension. And they start to deteriorate gradually, but the cornerstone of the treatment of TRALI or ARDS is actually just mechanical ventilation with lung protective ventilation to 6 mils per kilogram ideal body weight, high PEEP, and then prone positioning if you can, and ECMO. And then if the patient makes it, or does not in extreme situations, you have to go through the clinical governance aspect of things, debrief the team, try and not understand what went well, what could have gone better, and then set up a training protocol which will improve and prevent the situation from happening later on. And this is something we've been doing in Oxford, which is called excellence reporting. And in the majority of time when things go well, we actually look at why it went well so that we can improve it and actually work around it to improve things. And don't underestimate the emotional impact that this has on patients. They will have a post-traumatic stress disorder situation related to this, and they will need to be counseled later on. And not only the patients, also the healthcare providers, which is us, will have the second victim effect. We'll feel a lot of guilt, depressed, and then we can ultimately, if we don't vent off, we can feel burnt out. So the take-home message is you need to plan, train, prepare, give tranexamic acid as soon as possible, and transfuse fresh frozen and packed red cells in a ratio of 1:1. This is a protocol where we have at Oxford, where when we have a major hemorrhage, we just activate this, and we instantaneously get a box with 6 units of blood and 4 units of FFP, and we give tranexamic acid. And if bleeding is still ongoing, we get another box, and that other box will contain 6 more units of blood, 4 more units of FFP, a pool of platelets, and 2 units of cryo. And on that note, I'd like to highlight that Oxford is a sister city with Ramallah, Palestine, which is something I'm quite proud of. And to end this, I'd like to say thank you very much. Just remember that all bleeding eventually stops. Thank you.